So we conducted this pooled analysis because we have now looked at HRD, MyChoice HRD, and its ability to predict pathologic complete response in 6 different individual studies that all contain a platinum agent as part of the regimen. And we wanted to pool all the data because if you look at each individual study, the numbers are quite small. And so we wanted to combine all of these different studies which contain a platinum as part of the regimen and demonstrate the ability of MyChoice HRD to predict pathologic complete response in the tumors that were HRD positive versus those that were HRD negative. So we had a total of 267 patients in this study, and in the individual studies, we had a study that had 31 patients, another study that had 48, so we were able to combine and use the power of this combined analysis to demonstrate our endpoint. That's a great question. So they all had a platinum. So one study, patients only got platinum in the neoadjuvant setting. They got cisplatin only. In another study, they had cisplatin plus bevacizumab. In a third study, they had carboplatin plus Abraxane, which is a taxane-like drug. In a fourth study, they had carboplatin plus eribulin, which is also a Taxol-like drug. And in the fifth study, they had platinum, carboplatin, gemcitabine, and nipirib. And in the last study, they had paclitaxel, Doxil, which is a type of anthracycline, bevacizumab, and carboplatin. So as you can see, there was a variety of different regimens ranging from platinum only to 4 drug therapy. HRD is the result is that patients' tumors are either HR deficient, and that's above a threshold that we defined. So it's above the number 42. So the scale of our test is 0 to 100. If the tumor result is a 42 or higher, we call that tumor HR deficient. If the result is less than 42, it's HR non-deficient. And the way that we came up with that threshold is our assay is really designed to identify tumors outside of those that have a BRCA mutation, but they behave like they have a BRCA mutation in terms of their sensitivity to chemotherapy and agents like PARP inhibitors and platinum. And so our test was designed to capture 95% of all tumors that have a BRCA mutation, and that was our threshold. And we know that there are a number of tumors that sit above that threshold that don't have a mutation in BRCA2 or BRCA1, but they behave like they do. And so the result of MyChoice HRD is either you have a deficient tumor based on that score, or the tumor has a mutation, because we want to capture that 5% of BRCA-associated tumors that is below the threshold. The primary findings in this study, comprised of 267 patients, are that tumors that were MyChoice HRD positive were 5 times more likely to obtain a pathologic complete response than tumors that were HRD MyChoice negative. And that's a very robust number. So it's really important because it shows that the test is able to identify patients likely to achieve a pCR across many different regimens. The take-home message would be that this study, this assay, has been highly studied, is robust and reproducible across many different studies to identify patients who are likely to respond to platinum. We have additional validation studies being planned that, when complete, we feel the test will be ready to be used clinically to help physicians and patients make choices about what patients should be receiving platinum as part of their regimen based on their HRD result.